All right, and I'm going to share my screen and we're going to dive in here. All right, can everybody see my screen though? Perfect. Okay, so when you go in here, I want to go into our modules. I want us to all be on the same page as far as what is due this week, what we're going to be expecting for next week, because these next 2 weeks are probably two of the heavier weeks as far as coursework and homework goes. All right, so let's go down. We'll scroll down to week 6. This week, you guys have your Saunders questions, your NCLEX question number 2 assignment. You also have your placenta previa sim chart assignment. Oh, where'd that go? There it is. And then you have your quiz 4, which is now considered homework that you guys can do after class this evening. I might have to go in and change that date because it looks like you guys don't have access to it yet or something. So I'll check on
So
that.
are the quizzes due? They're due Wednesday night.
I believe you guys have until Sunday to do them.
Okay,
Yeah,
only
she said
because
Sunday. She said Zella said Sunday.
Yeah.
from last week mine says
Mhm.
late, even though I did it on Saturday. But I was like, was there like a disconnect there or something? Okay.
No,
Same.
I'm gonna go in and I'll change the due date for those. It looks like the due dates are all still programmed to be, well, some of them are programmed to be on for that Wednesday submission. So I'll go into last week's and change it that way it doesn't pop up or populate as late for anybody. But yes, you guys should have until Sunday night of the modules to submit this quiz because it's now considered homework. So it's just how we do with all the other assignments.
Awesome. Thank you.
Yeah, no worries. Um, Really quick, I want to go into this NCLEX stuff because I've had a lot of questions about how we submit them, what the format should be, how to complete them. So I want you guys to see where we can find that information and let's go through it really fast together. So if you click into the homework assignment itself, okay, you're going to have all of these directions and it takes you step by step where to go, what category and subcategory the questions need to be under whenever you start this assignment, how many you need to do, and then how to save it and upload it to Canvas. Okay, so let's go through this together really quick. So you are going to select week 6 NCLEX review questions button to be redirected to the proper website. On this page, you're going to select mode, exam, and then 50 questions in step 1. Your category for this assignment or for this week's Saunders questions is not the same as it was for that first assignment. It is different, okay? So make sure you're paying really good attention when you go to complete this, okay? So your category this week is going to be health problem. Your subcategory will be maternity, okay? And then you're going to go in and still select new questions only, and then you'll start your session. You need to do at least 50 questions. I've had some people ask if you're not happy with your grade after you've answered the 50 questions, you're more than welcome to take more questions to increase that score before you turn it in. We just say a minimum of 50 questions. So if you want to do more to increase the grade that you're getting, you're more than welcome to do that. Okay. After you have gotten the grade you're happy with, after you've completed the minimum of 50 questions, you're going to select exam results to be submitted, say print results, and then you're going to save it as a PDF. If you guys have already submitted your 50 questions, contact me separate, especially if you didn't do the correct category. Since we just went over it tonight, I will be fine with you guys redoing the assignment. Okay.
Okay, question, because I had selected like the intrapartum or something. Like I did this next drop down of maternity and still did the 50 questions.
Okay.
So it's like what we're talking about these last couple weeks.
Gotcha. Okay.
So
Um,
so it's still like within maternity and everything and all the questions, but is
it
that going to be wrong?
It should be fine if it
Okay.
gave you 50 questions and it's underneath
Yeah.
health problem and it's under the subcategory of maternity. That
Yeah,
should be
it's
perfectly fine.
all those categories. It's just like the subcategory then of the next of like maternity. So
Gotcha.
it
Yeah,
just yeah.
that should be totally fine for sure.
Okay. Okay.
I
Um,
did the same thing like Brittany. I done the same thing. So
okay,
good.
that should be okay. I'll look through it. And if I need you to change it, since this is the first week that I'm grading this assignment, I'll let you guys resubmit. If there's for some reason something comes up and it's saying that you like it's not going to let me give you full credit or whatever, I'll just reach out and I'll have you guys resubmit it. Okay.
Okay, thanks.
Yeah. So you're going to save it as a PDF. You do need to use the proper file naming for this assignment. I'm sure Dr. Zeller told you guys about this. You need to submit your file with this name similar to how it is on here. Okay. Nurse 202 underscore week 6 underscore NCLEX underscore your first initial last name underscore date. All right. So if you have any questions about, okay, like where do I go, what categories, please come in under the module, under the assignment, and it will tell you step by step what you need to select and how you need to complete it. Okay. This will be due by Sunday night of this weekend. Um, then you have your Synchart Placenta Previa, and then like we said, we have our quiz 4. All right. Let's look ahead to week 7. You guys will not have access to week 7 until Sunday night at midnight, okay? That's when the modules are supposed to open so that you guys can have access to that following week. Prior to that, we just don't want you guys working ahead. That's why they're locked and you cannot start these assignments until the Sunday night of the module, okay? Next week, you have your discussion 3. So for discussion number 3, your initial response to the prompt needs to be submitted by Wednesday night at midnight, okay? Your initial response. You need to submit your response to your peers, the two peer responses, by Sunday night at midnight, okay? You should be posting these on 2 separate days. So you're going to have a total of 3 posts that need to be posted on at least 2 separate days, but everything needs to be in by Sunday night, okay? Unfortunately, if you do not submit your initial post by Wednesday night at midnight, you will get that late penalty, that 10% late penalty, because we want you to have it in by Wednesday. All right. The other main reason why I wanted to jump into Canvas is because we have our teaching plan coming up. And I know that it's on your syllabus and we may have talked about it in orientation. I'm not sure if Dr. Zeller went over this at all with you guys yet or not. But I wanted to get in here and talk about this a little bit because it is a different assignment than what we're used to. And I want you guys to be successful and I don't want you guys losing homework points because of this. So let's go ahead and go over this. But like I said, you're not even going to have access to work on this until Sunday when week 7 opens. All right. So the teaching plan is basically an assignment where you guys are going to be the nurses on maternal and newborn units, and you have been asked to develop a teaching plan for mothers of preterm babies. All right. So this is basically an educational project. This is something that you're making to present to a family member or a parent of a baby that's being discharged home that was premature. All right. So let's talk about format first. Typically, in the past, the students that I've had who've been very successful with this project have just done a PowerPoint, and it's been very easy for them to complete it as a PowerPoint. All right. That being said, you don't have to do a PowerPoint. If you want to do a Word document, if you want to do a one of the presentation boards, like a poster board on PowerPoint or something, you can submit it that way. One thing I would encourage you guys to do, it says that you can do like a video presentation. I personally would just steer clear of that because I had like 2 students who submitted me a video presentation and it wasn't transferring well on Canvas. I couldn't open the attachments. They had to ultimately redo it and submit it as a PowerPoint anyway. Okay. So just a heads up, that might not be the number one thing that I would use when we're doing this. Okay. So what you're going to do with this PowerPoint is you're going to document, the first part of your project should be a documented full head-to-toe assessment on a preterm neonate, focusing on both normal and abnormal findings. You're going to identify at least 2 abnormal findings to consider as you develop your teaching plan. All right. So you're going to just go through a head-to-toe assessment on a baby, on a preterm, and then you can either have your abnormal findings highlighted or bolded or whatever. They need to stand out. So I need to be able to see like which ones are the abnormal findings you're referring to. Um, and then the rest of it, just go through a normal head to toe. Okay. And then after you've done that, you're going to be developing your going home teaching plan that is going to include each of these following bullet points. And what students have done in the past, and they've been very successful with this, is they will just create an individual PowerPoint page for each one of these. Like they'll have their own slide, each one of these topics. All right. And then they just address each of the topics um, as their project. All right. So, safety concerns for preterm newborns, symptoms to report to our pediatricians, follow up appointments, skincare and feeding, infection control, community resources, and support groups. Okay. When I go through and grade these guys, like I'm looking at your head to toes. I want you to be detailed. I want you to be focused on making sure that head to toe is complete. When it comes to these groups of bullet point, I'm just making sure that you have them included. All right. I want you guys just to have this and I want you to have good information underneath each of them. But I literally just look to see and make sure that you've covered all these topics to get full credit. All right. Like I said, you can use whatever type of format, but PowerPoint has proven to be the most effective, and students find it a lot easier. All right. You also need to make sure that you are including all of your citations for the information that you are getting, okay? And the reason I say this because, well, like, duh, we're in nursing school. We know we need to cite our sources, right? But for this is the only project that I have to submit it to a plagiarism tool, okay? So it's going to flag anything that you guys have that is not properly cited, okay? That being said, too, if you have taken this class already, if you are a repeat student, please redo this. Please redo your project because if I submit it into the plagiarism tool, it's going to flag you as 100% plagiarized because it will have already been submitted in a previous term. Okay. So you do need to redo it if you've taken this class before. All right. And then if you scroll down, you'll be able to see the exact rubric that I'm going to be using whenever I grade your guys' projects. All right. If you choose to do it as a Word document, that's perfectly fine, but please don't just submit like a Times New Roman 12 point paper. Like there's no creative or anything, no pictures, nothing. Like, because it's part of it is supposed to be creative, it's supposed to be attention grabbing, it's supposed to be educational. So we want to make it so that the parents or like whoever you would be giving this education to actually want to read it, not just say, here's my paper, type of thing. So, um, include some creativity with it as well. All right. Anyone have questions over this? Awesome. If you think of anything, obviously, please, shoot me a message on Canvas. We'll go over it again next Wednesday before you guys submit. But I wanted you guys to be aware of it because you also have exam two next week, right? So I'm sure at the beginning of the week, you guys are going to be focused more on studying for your exam, not necessarily so much on getting your discussion posts and your teaching plans completed. So I just wanted us to go over this now for a few minutes. Back to week 7. So then you also have your another SIM chart that will be due, and then we have our unit exam number 2. What just happened? Okay. For the exam next week, it's the same thing as what happened with the first exam. You guys should probably try and get into the Zoom early rather than late. I'll have make sure you guys have your Fortis ID. You have your 2 devices for testing. You're welcome to have that dry erase board while you test. Once everybody is in the Zoom, we'll do a check-in with everyone, and then we'll take our test. You have 75 minutes. Everyone takes their time. I always, after the exams, give everybody a 15-minute break because I just feel like everyone should have a little bit of a breather after a test before we dive right back into material. So we'll take our break, we'll come together, and we'll go through what we need to go through next week. All right. In regards to our exam, I wanted to go into our announcements page and show you guys something real quick. I posted this exam 2 review schedule yesterday. That was when all the professors got their exam 2 review times to everyone. This review session schedule here includes the date, who the professor is, as well as their Zoom ID, okay? I already had mine today. It was at 3 p.m. I've uploaded my recording here, so if you guys want to watch that and review that way, you're more than welcome to, okay? I personally used this PowerPoint, which I've included at the bottom here for you, this exam to review PowerPoint, and it has 40 different questions, practice questions that include multiple choice, select all that apply, and dosage calculations.
I was looking at that. It's very helpful. I was looking at that. I made me like a little homework thing with it. And
Good.
yeah, I was looking at that. I
Awesome.
like it.
Awesome. I'm glad you enjoyed it. It's there for your help for you to help you. So yes, if it works for you, keep there will be another one that I'll post for exam 3. So it'll be very similar to this one. Okay. But that is what I did for my exam review today. So if you guys want to print off that PowerPoint or download it or whatever, that is there for you. Okay. If you have the chance to go to um, another professor's review this week, please do. I think
The
that
boy that we just did is the CEO of who?
He's the son of
Oh, okay.
can everyone make sure that they're muted? I'm not sure who's
Oh,
talking.
my muffins. I'll go get him right now.
Okay, I got it. So if you guys have time, go ahead and go to a review session if you have the time this week to do so. Okay, they're all very helpful. Um,
Do you know if those are in Eastern time, Professor Young, or
yeah, they're all
okay,
at Eastern time. Yep.
okay,
All
perfect.
right. And then I think the only other thing I wanted to show us today was the Welcome to Week 6 announcement, which is very similar to the Welcome to Week 5 announcement. Okay, we'll just go through it real fast. So I have my Zoom link here for people who are struggling or cannot find where to come or how to get into Zoom. This is the link that will bring you directly to my page. Okay. These here are some class 5 activities that we didn't do last week, but I wanted you guys still to have access to them. So there's like a practice case study, and then there's also some NCLEX formatted questions for you guys for practice. All right. So if you can review those, if you want just some extra stuff. And then it goes through here, our weekly assignments, and then at the bottom here is our PowerPoint that we're going to be lecturing in today. I had some students reach out who may or may not have struggled with that OB math assignment. If that pertains to you, or if you want extra practice, let me show you where you can go. If you scroll down in this announcements page, there's an announcement here titled Math Practice. This has some documents in there that gives you practice problems, it gives you the solutions, it gives you the answers, all that good stuff. Okay. So this is something here that you can go to if you want some more practice with math. All right. Everybody's OB Math 2 calculations grade should be up to date now. I went in yesterday. Was it yesterday? No, Monday. Monday evening and yesterday, and went through and graded everybody's. The reason that it came up for some of you, like you got a 0 out of 12, you are not terrible at math. The thing just like grades you because if you don't include your unit of measurement, it gave you a 0. I'm not going to give you a 0 for not including your unit of measurement. I think that we're all learning and we need to have some grace. So I gave you points back on that. The other thing that happened was if you put in your answer and then immediately tacked on your unit of measurement, like without including a space between the two, it gave you a 0. So that is not wrong. You guys got the answer right. So I went in and changed all of that. If you got an answer wrong simply because like the math was it was confusing or whatever whatever it may be, I put the number, the problem number, and as well as the solution for you in my comments in your assignment, so you can go in and review the correct answer. All right. All of that should be up to date. The quiz 3 grades should be up to date too. I'll go in and make sure nobody's getting like late penalties for that because if you turned it in before Sunday, it will be fine. So our grade book should be pretty much set for now. All right. If everyone could also make sure their first and last name is on their Zoom, because I have to use it for attendance. So if you can just put your first and last name in there for me, and if you don't know how, I can do it for you.
Do you mind doing mine? I'm so sorry. I'm logging at work from my phone and I've never used Zoom on my phone, so I'm having a hard time.
You're fine. Can you spell your first and last name for me?
The first name is Abigail, Abigail. Last name is Landin, Landon.
All right. Perfect. Thank you.
Thank you.
All right, guys. So let's go ahead. We have quite a bit to cover today. Is everyone okay with not taking a break and just shooting me a message if you need to get up for something, and we'll end class around 8 o'clock? Is that all right with everyone again? Okay. Awesome. I'm seeing a lot of head shaking. If you need to go to the bathroom or get a snack or whatever, please feel free to do so. Just shoot me a message in Canvas so I know where we're going, and we'll dive into the material for this week. It is a lot of information, okay? So please don't let this completely overwhelm you. As you're studying for our tests, I want us to really focus and prioritize the information that is included in these PowerPoints, okay? The stuff we're going over in class is the main bulk of the stuff that I want you guys to know for your exams, all right? If there is ever a point where you guys don't know, like, how to study, what to study, please send me a message on Canvas and we can set up a time for individual tutoring. I would love to spend some time with you if you need. Um, so just keep me updated on how you're doing and if anybody wants extra practice or tutoring, okay? All right. If my thing loads, that would be great. All right. So this week we are in chapter 17 in our textbook, which is our chapter regarding high-risk labor and birth complications. We're gonna talk about a wide spectrum of complications that we see very typically and very frequently in labor and delivery. Most of the time, it spans anywhere from preterm delivery, preterm birth, small for gestational age babies, IUGR, membrane rupture. We're going to talk about OB procedures like versions. We'll talk about assisted deliveries, so like our vacuum kiwi deliveries, forceps deliveries, cesarean births. We're going to talk about that. And we need to be able to understand these because not only, for the purpose of our exams, but we want to be able to provide safe and efficient care to these high-risk labors, right? And know what we need to do and in what situations. So jumping right in, I need you guys definitely for the exam to understand this terminology here. Know these definitions, know these parameters, know what is considered preterm labor, know what is considered preterm birth. So we're going to go through these here for a couple minutes. So preterm labor is defined as regular uterine contractions, including cervical changes, before a patient is 37 weeks gestation. Okay, so what does this mean? If a mom comes in and she's having uterine contractions, but she is not making cervical change, she is not in preterm labor, right? Because we can have Braxton Hicks contractions, we can have uterine irritability, we can have dystocia or uterine dystocia where like something is happening, maybe mom's dehydrated or whatever. This does not necessarily mean that she's in labor, right? So if we have a mom who's 34 weeks who comes in, she's having every 2-minute contractions on the monitor, but we check her cervix after 4 hours and she's not made any cervical change, she's not in labor, okay? Those uterine contractions are being caused by something else. So you need to have both the contractions and cervical change for it to be considered preterm labor, okay? Before 37 weeks of gestation. Preterm birth is a delivery of an infant between 20 weeks of gestation all the way up until 36 weeks and 6 days of gestation, right? A very preterm birth would be a baby that is delivered before 32 weeks. This is when we see the highest rates of morbidity, fetal morbidity. We also see prolonged NICU NICU stays, prolonged hospitalization. We also can see these babies have other types of medical conditions that arise because they were born so early. So these would be our very preterm infants. Late preterm infants are any babies that are born 34 weeks up until 36 weeks and 6 days. All right. There is still risk associated with delivering in this window. Okay. But we also, if we're delivering in this window, need to outweigh risk versus benefit. Is it safer for the baby to be born in this window of time, or is it safer for them to continue on in the pregnancy? And unfortunately, the only way we can answer that question is per patient and what is happening in the situation. All right. Whenever we talk about preterm labor and birth, we need to mention weight classifications because oftentimes if a baby is born early, they are going to be small, right? Not always, okay, but most of the time we're expecting a small baby if these babies are coming early. So a low birth weight infant would be classified as any baby that is under 2,500 grams. Okay. Some things that can cause low birth weight besides a baby being early, a major one is intrauterine growth restriction, which, as we remember from last week, intrauterine growth restriction is caused by quite a few things, right? Substance use, cigarette use, um, anything like that in pregnancy, mom having hypertension, uncontrolled hypertension can cause IUGR. Uterine abnormality can cause IUGR. So we needed to be aware of this, and these are babies that are going to be monitored pretty closely if we do get diagnosed with an IUGR in pregnancy. All right. Um, with preterm labor and birth, we also need to realize that there are different kinds of preterm birth that can be classified. So we have spontaneous preterm birth, meaning mom comes in, there's maybe not even anything going on underlying with mom or baby, so it's not related to any maternal or fetal illnesses. It just happens spontaneously. Mom comes in, she's early, she's contracting, she's making cervical change, and spontaneously has a baby premature. An indicated or iatrogenic preterm birth is done, it is a medical decision made by the OBGYN to resolve maternal or fetal risk. So that could be in our moms with severe preeclampsia. That could be in our babies with severe IUGR or a growth restriction. That could be in a patient who has oligohydramnios. That could be in a patient that has, most of the time it's with that eclampsia or preeclampsia that we're looking at a medically indicated preterm delivery. Okay. So we need to know that there are some times where it is indicated to take a baby early. And if we have to, how are we going to manage that, which we'll talk about here in a couple slides. Preterm labor and birth can be caused by a couple of different things. All right. A major one is infection. So if a mom has reoccurring yeast infection or bacterial vaginosis or has a new onset of an STD or has a reoccurring onset of an STD, that can all irritate the cervix. That can send mom into preterm labor. This is the most common trigger for a mom between 30 and 32 weeks of pregnancy. All right. So a new onset of infection at that window can cause cervical change, can cause cervical irritation, and lead to a preterm labor and birth. All right. Intra-abdominal infection would be, an example could be chorioamnionitis. All right. Then that's an infection of the amniotic fluid surrounding the baby. Okay. If we have a known and diagnosed case of chorioamnionitis, that is something that could cause preterm labor and birth, and that also could be an indication for a medically induced preterm delivery. All right. Periodontal disease also can lead to preterm labor and delivery. So that's why we stress the importance of dental hygiene and moms following very closely with the dentist throughout their pregnancy, because that can lead to preterm birth. When we look at structural abnormalities, so we're talking mostly about uterine or cervical anomalies. So if mom has a bicornate uterus or a heart-shaped uterus or a uterus that has a septum that splits it down the middle, okay, that can increase her risk for preterm labor and birth because you have to think about it. If a baby is growing in only one half of the uterus, that can lead to intrauterine growth restriction, that can lead to preterm labor, right? Cervical anomalies, we're not going to go as far to say as cervical insufficiency, which is what we talked about last week, wherever moms are having the multiple second or third trimester early deliveries because their cervix will just dilate on its own. But we can also talk about like if there's any scarring or any tissue, if mom has had to have a cerclage in the past, if she has a very friable cervix and she's had a lot of bleeding throughout this pregnancy. Those are things that can indicate that the baby is going to come earlier, that we may need to take this baby earlier. Abnormal placental implantation. So that goes back to when we were talking about with our percreta, increta, accretas. Okay. When that placenta attaches or implants itself further into the myometrial layer, sometimes even as far as adhesing to other organs, adjacent organs. Okay. If that kind of stuff is happening and we are able to diagnose it via ultrasound, they're going to take this mom earlier, and for something like that, it may be indicated to have a cesarean delivery, right? Just to prevent her from hemorrhaging or having too much postpartum complications. Unexplained bleeding after the first trimester without identifiable cause can indicate that this mom potentially might have a preterm delivery. And then stress and other factors such as uterine overdistension, allergic reactions, and decreased progesterone levels. What does it mean when it says uterine overdistension? What are some things that can cause that?
Distended bladder.
I like where you're going with that, but not quite. That can cause postpartum hemorrhage if our bladder is really full.
Too much amniotic fluid?
Yes, polyhydramnios. So why would that cause uterine overdistension?
Everything's way too full.
Yep, you got it. You got it. I just wanted you to break it down for us. Correct. So what's another thing maybe that could cause our uterus to be too full?
She's had twins before.
Yeah, twins. She has a current twin pregnancy.
What is it? Macrosomia?
Yes, a
Is that a too big baby?
You got it. Big babies. Uh-huh. So you guys listed the big ones. So polyhydramnios. If a mom has too much fluid, that's going to cause uterine overdistension, right? That uterus is full, pushed to the capacity. A macrosomic infant, big baby. That's a big overdistended uterus. Okay. Multiple gestations. That uterus is going to be stretched to the max. Another one, which can be included with any of the things that we just mentioned, would be a post-dates pregnancy, right? Because usually if a mom's post-dates, the likelihood of having a bigger baby is increased. Okay, that uterus is stretched to the max. All right. If mom has an allergic reaction, especially in an anaphylactic sense, she could go into preterm labor. Decreased progesterone levels because then her body isn't going to be able to supply what to sustain the pregnancy all the way till term. That can cause preterm labor and birth. So, how are we going to predict and prevent spontaneous preterm deliveries? All right. There are two things that we use a lot to diagnose or can give us an idea of if a mom is at risk for a preterm birth. They are fetal fibronectin swabs and a cervical length exam. A FFN is a swab that we can use at the bedside. The OB nurses will perform this. You swab up into the inside of the cervix, swab around for a minute or so, and you send it off to the lab. What we're looking for is a glycoprotein related to placenta inflammation. All right. If the FFN comes back negative, that is going to tell us who is not going to go into preterm labor. So this is a little confusing because if an FFN comes back and is positive, that doesn't necessarily mean the patient's going to go into preterm labor. It just says that there's that protein present. Okay. But what's most reliable is a negative result for a fetal fibronectin. All right. A negative result will definitely tell us that this patient is not at risk for preterm labor. The one that I prefer, I do the FFN results a lot, but I think a lot of OBGYNs are trying to steer away from them. It is a useful finding. It rules out imminent preterm labor. But one of the ones that we see as far as imaging goes is the cervical length. This is something that we can see from a transvaginal exam on ultrasound, and it measures how long a patient's cervix is. If a patient's cervix is greater than 30 millimeters in length in the second and third trimester, that's very reassuring and is indicating that this patient most likely will not go into preterm labor. Okay. If they have a short cervix, which is often diagnosed during an anatomy scan, that patient may be put on progesterone because progesterone is going to
Oh,
help
yeah.
strengthen the
Yeah.
cervix.
Yeah.
So that is something that that could be indicated for progesterone use in pregnancies if a patient has a short cervix. Okay. So these two tests are going to be our most reliable indicators for if a patient's going to or trying to predict if a patient will be in preterm labor. Other prevention strategies would be health promotion and lifestyle modification. So, diet, exercise, management of a healthy lifestyle. We also need to ensure that they're getting adequate preconception counseling to identify correctable risk factors. So, what does that mean? Does the mom actively smoke cigarettes? Is she actively using or abusing any other substances? Because those can put you at risk for preterm labor. So we need to get them connected with counseling or therapy or also pharmacological intervention if necessary to try and reduce this risk. Um, Prophylactic progesterone can be used for patients with a history of preterm birth or a short cervix, kind of like I had mentioned when we talked about cervical length. Okay. That being said, though, if it's a mom's first pregnancy, and she goes and she delivers at 33 weeks, and then they realize, like, oh, you had some cervical insufficiency or you have a short cervix, that first pregnancy, they're not going to prophylactically put her on progesterone, but it will be an indicator in her history for her to be put on progesterone the next pregnancy, potentially. All right. Or at least managed a little bit more closely than she may have been on that first one. All right. Recognizing signs and symptoms of preterm labor. And this can be a little bit tricky because not every patient is going to present to you textbook the same and on the OB floor. Okay. We know that our preterm labor is defined as regular uterine contractions that include cervical change occurring before 37 weeks of gestation. Um, and these are things that anytime a mom calls into the unit and complains of them, we need to take these complaints seriously and encourage her to come in to be evaluated. Okay. OB is one of those units where if a patient calls in and has any doubt or any question about their safety or the safety of their baby, we should encourage them to come in and rule things out. Okay. So, and oftentimes, too, like not often, I shouldn't say, but sometimes if a mom is in preterm labor, she may not have any of these signs or symptoms. Like, this could just be a standard OB visit and they do a cervical check or they'll do some type of a scan and they realize that the mom is making change or something is going on that is indicating she's in labor. Okay. So some of the things that we can see though that a patient may present with would be vaginal discharge changes. So that could be a change in the consistency, that could be a change in the amount, that could be a change in the color, a change in the odor, an increase in volume, like they all of a sudden are starting to have so much vaginal discharge when before early in the pregnancy they had maybe none. Um, so if it becomes like watery or mucoid or blood tinged, okay, or we have that increase in volume, that could indicate that the patient's cervix is making change, right? Like bloody show. Is that cervix dilating? Or has her water broke? Does she have a rupture of membrane? So both of those things we need to have her come into the unit to be evaluated for. Pelvic and abdominal pressure. If a patient complains of a sensation of feeling heavy in her pelvis or lower abdomen, um, they may say like, "Oh, I feel like my baby is bearing down," or "I just feel like a lot of pressure in my bottom." This is an early warning sign of preterm labor, okay, and something we should take seriously, and also probably get an ultrasound to see where this baby is at. A low, dull backache. So a consistent or constant low-grade backache that differs from typical pregnancy discomfort. Those can be contractions that a mom is feeling. It just might be presenting as a backache for her, okay? So if she complains of this, especially if she is early gestationally, she needs to come in and be put on the monitor because she could be having contractions and we need to address that. All right. And then finally, contractions and cramping. So she has those regular or frequent uterine tightenings, even if it's painless, along with mild abdominal cramps with or without diarrhea, and possible rupture of membranes are all hallmark signs requiring immediate triage. All right. Um, Quick question for you guys to kind of get your brains moving here. If a patient comes in and they are 32 weeks pregnant, are we going to check their cervix? Are we going to perform a cervical check
Yes.
with our
I
fingers?
say yes.
I would not. No.
No, you don't
No,
want to
not with the
get more
finger.
infection.
So we could increase our risk of infection. Yes, that's true. We also run the risk of if we put our fingers up there and we're like stirring stuff around, we could ultimately send them into labor if they're
Oh, yes, labor.
irritated. So I personally, like as a bedside nurse, everything is different per provider and per policy. I don't check anybody that is earlier than 35 weeks gestation without getting a verbal order from a provider. And I would document that before. Like provider states it is okay at this time to perform vaginal exam, right? Most of the time with our early patients, they're not performing these exams using their fingers. They're going to be doing a speculum exam where they can actively visualize the cervix itself rather than introducing something into the vagina. All right. Um, Another question for you. If you have a patient who comes in who has no like prenatal history, we don't have any documented ultrasounds, she's having bright red, painless vaginal discharge, and she's 34, 35-ish weeks pregnant, are we going to perform a um, cervical check? Why or why not?
If she's already bleeding, we definitely don't want to add to it.
Right? We don't want to add more irritation. We don't want to further irritate
Mhm.
the cervix. What would be something you'd want to rule out if she presents with that painless, bright red vaginal bleeding?
Placenta eruption.
Placenta rupture.
Not rupture, if it's bright red,
Um,
painless.
Previa.
Previa.
Yes, a placenta previa. Why would we not want to check the cervix of somebody who has a placenta previa?
Because the uterus is
not
in
in
the
the right
way.
place.
Or the cervix is in the way.
So
Or
not
no, the placenta is in the way of the cervix.
placenta is laying over top the cervix. So if we stick our fingers in there and try to feel for a baby's head, we run the risk of rupture, a placenta rupture. We could rupture that placenta. We could cause ultimately a placental abruption. We could cause it to separate away from that uterine wall. So we want to know for sure where this placenta is before we're just sticking our fingers trying to figure out where the baby's at or how dilated the patient is, right? That being said, if a mom is actively in labor and she's having frequent contractions and we really need to know where this baby is, if baby is descending, we would call our OB provider, get our OB there so that they can either do a speculum exam or they themselves can perform that cervical check um, to see where that baby is and how far dilated the patient is. All right. Um, but I'm always hesitant whenever a patient comes in presenting with vaginal bleeding to check her cervix unless I have a verbal order from a provider and we know exactly where that placenta is and we know her gestational age. Okay. All right. Risk factors for spontaneous preterm birth. So, a major thing that we need to know is OB history because an OB history or a clinical history can indicate how at risk this patient is for preterm delivery. So, if they've had prior spontaneous preterm births between 16 and 36 weeks, that immediately increases their risk and their chances of delivering another baby preterm. All right. If they've had a history of genital tract infections, colonization, or instrumentation, so they've had frequent reoccurring infections, that is going to also put them at risk. A uterine anomaly, like we kind of talked about, so that if they have a septum or a bicordate uterus, that's going to put them at an increased risk. That
Question.
Oh, sorry. Go ahead.
Sorry.
No, you're fine.
About the infections. Would that be like throughout their entire lifetime or just when they're pregnant? Like if somebody gets constant like UTIs or things like that, or BV, but they
Yeah.
have never been pregnant, will that still relate to this?
So it only really applies to in pregnancy. So
Okay.
we usually look like, okay, say this mom's like 30 weeks and she had a pretty severe case of BV towards the beginning of her pregnancy, right? Her likelihood of that reoccurring later in the pregnancy is elevated. So we want
Okay.
to manage and watch that really closely. But it mainly is pertaining to the infections that she has had during that pregnancy. So
Okay, so like having them in her throughout 20s and whatever isn't
yeah,
gonna
no, they're like, oh, okay, that's fine. So
increase the risks for this. Okay. Thank
right.
you.
Like if I like so one time I had a patient who had new onset trick during her pregnancy and had to get antibiotics. And the provider wanted her on a pretty extensive course of antibiotic treatment because that one can be reoccurring very easily. And then she ended up coming in at 32 weeks with signs and symptoms of preterm labor, and it's because she had a reoccurring infection. So
Okay.
we just really want to keep good track of it during the pregnancy. Anything that happened before a pregnancy is kind of like, all right, we'll make note of it, but we want to know for sure during.
Okay. Thank
Yeah.
you.
Mhm. It's a good question. Um, Another one I want to talk about here is use of assisted reproductive technology can increase that risk of preterm birth and delivery. Okay. Um, So some things to be aware of. That is why it is so important whenever we are having our initial prenatal visit to compile a very thorough H&P on these patients because we want to know everything that could possibly happen and it gives us an insight into what we can expect for this pregnancy. Okay. Behavioral and social risk factors. Cigarette smoking or substance use, pre-pregnancy underweight, so a BMI of under 19, or obesity, a BMI greater than 30. So if you have a mom who comes in who's had a history of eating disorders or is actively battling an eating disorder, they need to be put into nutritional counseling and talk with a therapist because we need to increase their nutritional intake so that their body can sustain this pregnancy. Same thing like with a patient who is obese, over 30 BMI. We need to have a conversation with them about lifestyle modification and changes because obesity in pregnancy raises its own risk factors like hypertension and gestational diabetes. All right. Patients that have limited education and low socioeconomic class. So if a patient doesn't have the means of transportation to the hospital and they don't have the means to get there for prenatal visits, so they have limited or no prenatal care or late entry into prenatal care, it's very hard for us to pinpoint those patients that are at risk for preterm deliveries if we haven't seen them at all during their gestational period. Okay. Um, Limited education is mainly referring to like we need to spend time educating patients who this may be their first pregnancy or they may not have access to resources where they can practice like safe sex practices, things like that. Okay. Because kind of going back to the infection risk, like if this is a new onset STD during pregnancy, that will increase their risk of preterm birth or preterm delivery. Okay. High levels of personal or environmental stress. And then, unfortunately, African Americans are linked to systemic health disparities. So, as bedside nurses, whenever we have patients of this specific population, we need to advocate for them extensively. We should be advocating for all of our patients, regardless of cultural, ethnic differences. But this group of individuals specifically are unfortunately linked to health disparities more frequently in this area of medicine. Okay. And then down here, no single risk factor is deterministic. A comprehensive individualized risk assessment at the first prenatal visit allows for us to provide those early interventions and improve our outcomes. All right, so early recognition and early treatment. All right. So we have a patient, let's say, who's in preterm birth. How are we going to recognize this? How are we going to treat it? And how are we going to diagnose it? So in this example, a patient has come in, she's got that pelvic pressure, she has a dull backache, and she's got uterine contractions or uterine tightening. One of the first things that we're going to do, obviously, is we want to get her blood pressure, we want to do her vital signs, we want to get baby on the monitor, make sure baby is doing okay. But one thing that we can use to slow down uterine contractions would be a medication group called tocolytics. All right. These are going to be used to suppress contractions. So over here, we have this little like mnemonic, it's not my time, for indomethacin, which is an NSAID, nifedipine, which is a calcium channel blocker, mag sulfate, and terbutaline, or terbutane. I can't say that word, I guess. But all of these can be used to slow down uterine contractions, relax that uterine muscle, and prevent us from making cervical dilation, cervical change. So I know magnesium is up here, and last week, we talked about how mag is used primarily to prevent seizures. All right. In this case, in a patient that's earlier than 32 weeks, sometimes a little bit after that, if the OB thinks it's appropriate, we can administer magnesium sulfate as a tocolytic to help relax that uterine muscle, to help hopefully slow down uterine contractions. And we're also going to give it because it acts as a neuroprotectant for our newborn. Okay, so studies have shown, research has shown that a newborn who is early, a very preterm baby, that receives magnesium sulfate in utero prior to delivery, it prevents them from developing cerebral palsy. It's a neuroprotectant, which is pretty awesome. So that's why one of the main reasons why we're going to consider giving MAG to preterm patients. All right, it helps protect our baby. Another thing we're going to do if a mom's in preterm birth is we're going to pull out that betamethasone, that steroid that we're going to give to help speed up baby's lung maturity and increase surfactant production in the fetal lungs. All right, this decreases our risk for respiratory distress syndrome and also decreases our NICU stays and shortens hospitalization. All right. And then we're also going to consider administering antibiotics. And if possible, if the patient is stable and you're working at a very small little hospital unit, we're going to transfer to a facility that is larger, that has more resources with a full neonatal resuscitation team available to them. All right, that's me. If I have a patient that comes in that's in early labor, we try really hard to get them somewhere that's bigger, okay? Because I work at like a tiny little LDRP. So we want them to be able to have a full NICU for when they deliver. So, kind of tied into preterm labor, sort of, would be premature rupture of membranes, okay? These two definitions over here, I want you guys definitely to know these, know the differences between these two things. We're going to talk about them here now. So, premature rupture of membranes would be the spontaneous rupture of the amniotic sac before any onset of labor at any gestational age. So that happened to yours truly. I was like 41 weeks. I didn't have a single contraction, no Braxton Hicks, nothing. And then one night I woke up and my water had broke and I still didn't have contractions on my own. All right. So that would be considered premature rupture of membranes. Even though I was 41 weeks, it's whenever your water breaks without any labor happening before. Okay. And then preterm premature rupture of membranes, or PPROM, is whenever there's premature rupture of membranes occurring before 37 weeks of gestation. And as you can imagine, this carries a significantly higher risk for our patients. And why do you think that is?
Could you repeat the question? Sorry.
You're fine. Why would premature rupture of membranes occurring before 37 weeks carry a significantly higher risk for our pregnancies?
Is it the full lung development?
So we
Big?
already got our baby, yes, from a fetal lung maturity standpoint.
Is it
Okay.
the Group B strep that hasn't been done yet?
So close, yes. I'm mostly talking in a broad sense infection. So your risk for infection with an early rupture of membranes is a lot higher because sometimes moms may not have realized their water broke, right? And then all of a sudden they have decreased fetal movement. They have strange looking vaginal discharge, odorous vaginal discharge. So it can carry significant higher risk because we're more concerned about infection developing. Mostly chorioamnionitis, which we're going to talk about here. So that is a major complication of premature rupture of membranes. Um, Chorio is that infection of the amniotic fluid, and it's kind of like C. diff. When you've smelled it and you've seen it, you will never forget what it smells and looks like. Okay? Choreo is not a pleasant scent. It is not. It is nasty. It does not smell very good. Usually at this point, if we are able to like identify it based on how it's presenting, the patient is not in a good way clinically. So these are things that we need to take note of too. Um, Other complications that are associated with PROM would be a placental abruption. We can sometimes have cord prolapse. So like especially in our preterm, premature rupture of membranes, if that baby is small or maybe they're not head down yet, or maybe their presenting part has not been fully applied onto the cervix and their water breaks, the chance of that cord slipping down and out underneath that presenting part and into the vagina and having a cord prolapse is increased. Okay. With any infection comes a risk for sepsis or another intrauterine infection. Hemorrhaging and retained placenta is at a higher risk with these. And then pulmonary hypoplasia if rupture occurs before 20 weeks. All right. So premature rupture of membranes is not something that we take lightly. They immediately want you to come in and be evaluated if there's any increase in vaginal discharge. And that's why we educate our patients so thoroughly on this during their pregnancies. So how are we going to manage this if a patient has premature rupture of membranes? Okay. So it's obviously going to be individualized based on how our gestational age and how this patient is presenting, right? So if they're earlier than 34 weeks, the risk of preterm delivery often outweighs infection risk. So we're going to maybe try and manage the pregnancy still and just monitor these patients closely. Like they're going to be hospitalized throughout the remainder of their gestation. They'll receive antibiotics and NSTs and all that stuff. Um, a lot of the times too, we're going based off of like, okay, how mature do we think these infant lungs are, right? Because that's going to tell us like that's part of that risk benefit scale. Like, are the fetal lungs mature enough to sustain this infant following delivery? Okay, so based on this little like wave thing here, any gestational age, we need to assess infection risk because that's our highest concern. All right. If they are over 34 weeks and their water breaks, we're probably going to just deliver the baby. Okay? They're not full term yet by any means, but they're late preterm to the point that we think this baby and their lungs will be able to sustain them after delivery, and it's safe for them to be delivered at that time. Earlier than 34 weeks, this is when we're going to hospitalize these patients. We're going to do expectant care. We're going to do uh, every day they're going to get 2 NSTs on the OB unit. We're going to be giving them round the clock antibiotics. They'll be getting magnesium. So these patients, we're going to be trying as hard as we can, excuse me, to prolong that gestational period and get the babies to a point where we feel confident that their lungs will be able to sustain them. All right. Let's talk more about choreo. So this is a bacterial infection of the amniotic cavity. Frequently develops after the onset of labor, especially whenever we have that premature rupture of membranes. So choreo is going to present pretty similarly to how any other infection is going to present in your mom. So mom is going to have a fever. She's going to have tachycardia. She'll have some uterine tenderness. And not just like uterine tenderness, like, oh yeah, that's kind of uncomfortable. Like I've had patients before where I'm trying to put the ultrasound monitor on their belly to listen to the baby's heart rate, and they're like jumping out of the bed, just simply having that ultrasound touching their skin, like on their stomach. So they're very, very tender. They'll have that purulent amniotic fluid. But the one I want you guys really to remember is fetal tachycardia, okay? Fetal tachycardia is one of the biggest indicators for infection in utero. whenever a mom comes to the hospital. Okay, so if baby's heart rate is sustained at 180 beats per minute, we've given her fluids, we've started antibiotics, we've done all these things, she's been ruptured for over 24 hours, it is safe to say that there is some type of infection developing. Okay, so definitely know that fetal tachycardia is an indicator of infection. Risks and management. From a newborn standpoint, we need to be aware and ready to treat newborn pneumonia, bacteremia, meningitis, respiratory distress syndrome, and cerebral palsy if they are born prematurely. From mom's standpoint, she most likely is going to have a dysfunctional labor if she has chorioamnionitis. All right, her uterus is not going to contract and work as effectively as a uterus that there is not an infection present. Okay. Treatments, we are going to administer broad spectrum antibiotics. And then it's also very important for you guys to know that if a patient has an active diagnosis of chorioamnionitis, tocolytic therapy is contraindicated. You cannot administer terbutaline or nifedipine to these patients, okay? Any of those tocolytics we should not be using if they have chorio. All right. So we talk about how dangerous a preterm baby is. We're now going to talk about a postterm pregnancy. So this is a pregnancy extending beyond 42 weeks of gestation. Um, this is the biggest risk is stillbirth. All right. Why is stillbirth such a big issue in a postterm pregnancy? Someone explain why this is common.
The placenta gets depleted of nutrition.
Yes, exactly. So if we have an old placenta that doesn't want to circulate and oxygenate as effectively, this baby is not getting what it needs to be sustained. All right. So yes, our placenta starts to poop out a little bit. Anything past 41 weeks is sometimes when we start seeing inductions, medically indicated inductions of labor. Um, so at 42 weeks or beyond, that is one tired placenta. Okay. So from a maternal standpoint, if we have a postterm pregnancy, she is most likely going to have some labor dystocia, meaning her labor is not going to run smoothly. She's not going to have adequate uterine contractions on her own. Her contraction pattern may be irregular. The contractions may be not firm or strong or effective in producing cervical change. Okay. We run the risk with an post-AIDS pregnancy to have a big baby, so a macrosomic infant. So mom is at risk of a perineal injury and other birth injuries relating to macrosomia. Hemorrhaging is a huge risk for a post-term pregnancy, and that can be tied into our uterus being too full, right? So if you have a really post-AIDS pregnancy, you have a macrosomic infant, you've got a really big uterus that's stretched all the way to the max, it's going to take a lot more effort and a lot more contractility to return that uterus back to its pre-pregnancy state. Okay, so if the uterus has to work harder to return it to its normal pre-pregnancy state, and it's already tired because it's depleted, it's gonna be hard to get that mom's uterus to cooperate following delivery of this infant. So with these patients, we oftentimes will see increased medication following these deliveries to help return that uterus to the pre-pregnancy state and increase contractility overall. Okay. These patients are also at an increased risk for a cesarean delivery due to dysfunctional labor and dystocia and all these other things that are listed above here. So sometimes they determine that it's just going to be safer for a mom to have a C-section rather than risk anything else. Okay. And then obviously fatigue and psychological distress is a risk factor for a mom. Okay, she's tired of being pregnant, man. She's 42 weeks. That is way too long to be pregnant. She's ready to have this baby. Um, and that's her focus. What do you do if you have a patient who is going on 42 weeks and 5 days and they are actively refusing a medical induction? How would you handle that?
You have to explain it to them. Do the
That's what holding the risk is.
yeah,
You can educate them.
educate them.
Yeah. So you've educated your patient, you've told them about the risk factors, and they're still like, no, I think I'm going to just wait until my body does it on its own.
Tell them to go walk a lot.
Go do your curb walks, girl. Let's do this.
Go walk.
Do you do you advise like sign the consent or some kind of statement?
I'm
No.
sorry, what was that? Can you repeat that?
It's like a consent that she's refusing
So the
or like a
Like
statement.
an AMA.
Yeah, so the OBGYN is going to document that on the patient's chart.
Okay.
Medical induction offered at this time or encouraged at this time, patient refusing, patient educated on risk of continuing the pregnancy. Yeah, that's definitely something that's going to be a CYA. Like we're gonna really make sure that we're charting and documenting that. Unfortunately, these things happen. I've had patients that have refused medical inductions, and it's for whatever reason, their reasoning to them is important, and that is what they are um, fighting for whenever they're actively refusing an induction. But you really just have to stress to the patient, hey, this is what is going to be the best for your baby. This is what the risk factors are. This is what could happen if you continue this pregnancy. And then the biggest thing that I would stress with a post-term pregnancy is you need to educate them on their fetal kick counts. Okay? If we have an increased risk for stillbirth, we need to educate them on fetal movement. That is the number one thing that I would educate this patient on. I'd be like, okay, if you're not wanting to do an induction, that's fine, but you probably shouldn't be going to work. You probably should be off your feet. You need to hydrate very well, and you need to always be doing your kick counts at the same time every day, and you should feel 10 fetal movements within 2 hours. If you don't, you need to come into the hospital immediately. And that's something I would stress pretty heavily with this group, with this patient. Okay, so from a fetal risk, whenever we're talking about post-term pregnancy, macrosomia, so a big baby, and the birth injuries that are accompanied with that, like clavicle fracture, brachial plexus injuries. An aging placenta, which means a decrease in estrogen production. So the body is beginning to not prioritize the pregnancy anymore because it's outside of that gestational window. That placenta is aging. That's going to lead to fetal hypoxia, right? Because our oxygenation is not going to be as efficient. Another thing that can happen is we're going to slowly have depleted amounts of amniotic fluid. So we're going to see oligohydramnios. If we don't have a lot of fluid, we don't have a good cushion around our umbilical cord, and that's going to cause cord compression. So baby's heart rate is going to drop because we have pressure on that umbilical cord. It's cutting off oxygenation to that baby, and baby's going to start showing signs and symptoms of fetal distress. What is something that we can see? What's an indicator of fetal distress that we may be able to see without having the baby on the monitor? This is kind of tricky. Really got to put your thinking caps on here.
Maybe the baby kicks.
So the baby's gonna do
Their
something.
position.
I mean, more she like rolling the baby, like rolls more in the
So the baby may
tummy.
not move more. Baby might be moving less in this instance,
Oh,
but it does have something to do with what the baby's gonna do.
Is it their position?
Not necessarily their position.
Not kicking, like moving, not moving.
So baby might have a bowel movement in utero.
Yeah, the meconium.
Yeah,
oh, the
baby might
ones
have a
that actually.
meconium. Baby might pass meconium. So meconium stained amniotic fluid indicates that our baby had some sort of stressful event happen in utero that caused them to have that initial bowel movement. Okay. So meconium can be something that is caused by a stressful trigger to the baby, and baby can pass that. Okay. If a baby enters into a hypoxic state in utero because there's cord compression, because oligohydramnios, because the mom is post-dates, that baby can pass meconium in utero, and we may see it if mom's water breaks, or yeah, if whenever mom's water breaks. All right. So that's something to keep in mind too. Um, and then because if baby had that meconium, because of all of these things, they're going to be at an increase for meconium aspiration syndrome, which is something we're going to talk about a little bit later in this presentation. So it's all kind of tied in together. You've got an old placenta, you've got low amniotic fluid, you've got that cord compression, baby's hypoxic, baby has a meconium, baby has a stool, baby swallows it coming out, and now we have meconium aspiration. All right, no good things, all bad things. So this is the stuff that I want you guys to know about postpartum pregnancy. All right. Let's talk now about dysfunctional labor or dystocia. So we learned the 5 Ps that was in, I think, week 1 or 2 of labor, the power, passage, passenger, position, and psyche. So labor dystocia is what we would define as a long, difficult, or abnormal labor pertaining to one or more of the 5 Ps. So when we talk about power, that is ineffective uterine contractions, and that can be primary or secondary dysfunction. So primary dysfunction would simply mean mom is not having contractions on her own. All right, for whatever reason, her baby's malpositioned, her body's not ready yet, she's preterm, whatever it may be. She may not be having uterine contractions. Secondary dysfunction would mean she's not pushing effectively whenever it's time to push. We're initiating medication, and the medication is still not giving us a good, reliable contraction pattern for whatever reason it may be. So, that is the example of power. Passage or mom's anatomy could indicate a pelvic diameter abnormality. Soft tissue obstruction, so like she has a placenta previa or there's cervical edema, or a uterine anomaly. What are some things that could cause cervical edema?
Could it be the pressure of the baby's head?
Yes. And typically, if it's in that sense, it's one-sided because usually baby's coming down asynclitic, so they're not providing standard pressure around the entire cervix, and it's on one side or the other. So you may see one side thinned out and appropriate, and then you may feel another side um, be very swollen and thick, and that's the cervical edema. So yeah, that's excellent. Um, Uterine anomalies, going back to that bicornate uterus or a septum, anything like that can impact how our labor is going to progress. Passenger, so how baby is positioned. So if baby is in malposition, they're not going to be applied effectively to the cervix to encourage appropriate uterine contraction and cervical dilation. So let's see. Um, Most of the time, butts are softer than heads, right? A baby butt is a lot softer than a baby head. So if your baby's butt is sitting on the cervix and it's being pushed down onto the cervix with a uterine contraction, it's not going to cause as effective cervical change as if a firm fetal head was resting on that cervix, right? So if a baby has a face presentation and their face is pressed up against that cervix, it's the same thing. Their uterus is contracting, but that face is the presenting part. It's not going to cause appropriate cervical dilation. Another big one would be cephalopelvic disproportion, simply meaning that that baby's head is not fitting into mom's pelvis appropriately. That baby is not fitting well. They're not able to come down through the birth canal. So vaginal delivery for this infant with a cephalopelvic disproportion may not be possible, just depending on the severity. Okay. And then finally, position and psyche. If mom is super, super, super stressed or is not able to fully relax, um, that during the uterine contractions, which is really hard, may I say, you are going to have mom's body actively working against herself, fighting against those contractions, not allowing that pressure to take place, not allowing baby's head to press down on the cervix, and it may cause cervical change to stall or to not happen at all. The stress hormones are also going to act on the uterine smooth muscle and not allow mom's uterus to contract as effectively. Okay. We see advanced maternal age can sometimes cause labor dystocia. So a mom that is in advanced maternal age may have a harder time having spontaneous labor or appropriate uterine contraction pattern. We see this a little bit more frequently with this patient population. And then lastly, epidural and anesthesia effects. Sometimes epidurals can slow down or stop uterine contractions. Okay. That is something that patients ask me all the time. Like, I'm already 6 centimeters dilated. Should I get an epidural or is it going to completely stall my labor? At 6 centimeters, I think you're going to be all right. I think we're past that point where we need to be worried about that. But if they're not even dilated at all and they're asking for an epidural, that's something that we should educate them on is, hey, like, um, you may want to wait a little bit. Excuse me. You may want to wait a little bit and let your body dilate just a little bit more because it does run the risk of stalling your labor. All right. So all these things can contribute to labor dysfunction or labor dystocia. Precipitous labor. These are crazy, okay? This is why I have had 10 RN deliveries, okay? Especially in Amish country. They do this a lot. The Amish do this a lot. This is a labor that lasts less than 3 hours from onset of birth from onset of labor to birth of the baby. So with this type of labor, we are seeing hypertonic contractions and rapid fetal descent. So mom is having crazy amounts of contractions. They are strong, they are effective, they are zooming through, and that baby is coming down the birth canal very, very, very quickly. Okay. As we can imagine, this has some risks associated with it. So, fetal complications, let's think about this. If you have a lot of uterine contractions, one after the other, are we worried about oxygenation of our baby?
Yes.
For sure, because that baby doesn't have the time to recover in between the uterine contractions effectively. So they are way more likely to have hypoxia, right? So our baby could be hypoxic because of uterine tachysystole, all right? We also are worried about intracranial trauma from rapid descent and rapid birth. We can sometimes see head injuries or complications like that. From a maternal standpoint, uterine rupture is a big one, and that is because of uterine tachysystole. If your uterus is working overtime and it's pumping out contractions every minute and they're very firm and they're very, very strong, very hard contractions, we run the risk of our uterus rupturing. It's like any muscle. If it's being overused, you run the risk of tearing it, straining it, so it's the same concept. Same with perineal lacerations. If you have a baby that's coming down really fast and mom has no control, we don't have time for the pelvic floor to stretch with the baby's head. That baby's just going to come right down through. Okay. Um, just because a mom has a precipitous labor, though, does not mean she's going to have intense lacerations. I've seen it before where a mom has had a precipitous delivery and she doesn't have a single perineal tear. But then I've also seen it where a mom's had a precipitous birth and she's had a fourth degree laceration. Okay. So it really just does depend on mom's anatomy and how that baby is coming down. With a precipitous labor, we run the risk of having an amniotic fluid embolus, which we'll talk about towards the end of this PowerPoint presentation. We go into that a little bit more in detail. The biggest one, though, that I want you guys definitely to know is with precipitous labor, we have a huge risk of postpartum hemorrhage. All right. Why do you guys think that is? Why are we at an increased risk for a bleed?
Everything's just moving so fast.
Yeah, definitely. Everything is happening very quickly. That uterus is working overtime. It's working really, really hard to get that baby birthed so quickly. So whenever your uterus finally delivers the baby, the uterus is going to be like, all right, my job's done. I did what I had to do. That baby's out. I can rest now. And then getting that uterus to increase contractility simply to come back to its pre-pregnancy state and prevent hemorrhage is a lot harder with these patients because that uterus is tired. It worked really hard. All right. So anytime we have hypertonic contractions or contractions like more than 5 contractions happening in a 10-minute period, we are worried about placental abruption, uterine tachysystole. Some things that we can see that cause this would also be cocaine use. So if a mom has recently used cocaine, this can cause hypertonic contractions. All right. And these things obviously can just happen. So I remember like recently I had a coworker who was triaging a patient and she was only like 37 weeks, I think, but it was like her third baby and she was in the hospital and she was like, I don't really feel comfortable going home because last time my baby was born like in the parking lot, I had a really fast delivery. And this nurse was like, "Oh, I think you're okay. You're literally like your cervix is closed, like you aren't having any uterine contractions." But the mom was feeling like really, really strange. So this nurse discharged this patient, and literally, I'm not even kidding you, 45 minutes later, this patient's being wheeled back up in a wheelchair, and the baby is being delivered in the wheelchair on the way to the room. So if you ever become a labor and delivery nurse, trust your patients when they tell you these things, okay? Just keep them a little longer and watch them because they will have these babies real fast. So we always want to take their word for it, all right? Moving right along, we'll talk about obesity and pregnancy. So this is defined as a BMI greater than 30, and it's associated with elevated risk during labor and birth. So labor risks, we see an increase in labor dystocia in this patient population, so dysfunctional labor, prolonged labor with these patients, and then these patients often will need augmented. So that means if they are having uterine contractions, most of the time in this patient population, the contractions are not effective, and we need to give them medication to strengthen the contractions that they're already having. Okay, that's what augmentation would mean. Um, from a fetal risk standpoint, anytime a mom is obese or there's obesity in pregnancy, we run the risk of having a really large baby, okay? Because sometimes with in obese patients, we have that gestational diabetes. Gestational diabetes can cause a macrosomic infant as well, a large baby. So we need to be prepared for that. With a big baby, we run the risk of having that shoulder dystocia, right? So we need to know how to, the McRoberts maneuver that we can implement to release that shoulder, that anterior shoulder. We also see an increased risk of stillbirth in obese patients, as well as in NICU admission. Okay. Delivery risks for this patient population, they sometimes will have a higher cesarean birth rate, and that is related to labor dystocia or just an abnormal labor pattern. Okay. We also will see wound complications. So, if you have a patient who is severely overweight or morbidly obese who has a cesarean section and their incision is underneath like a pannus or a skin fold, we need to try and keep that dry. We need to educate our patients on signs and symptoms of infection and educate the importance of keeping that area nice and clean and dry to prevent infection. All right. Anesthesia challenges with this patient population, sometimes they require more anesthesia, and that can cause some difficulties postpartum. Like they may be bedbound a little bit longer, we may need to recover them for a little bit longer, that those kind of things. And then finally, postpartum risk would be they're at an increased risk for hemorrhaging, venous thromboembolism, infection, and poor wound healing. All right, jumping around here, has anyone gotten to see or experience an external cephalic version? I'm not sure. Have you guys had your OB rotations yet? No. No. Okay.
I'm in now.
You're you're in it now?
Mhm.
Oh, nice. Okay. Have you gotten a chance to see a version or anything like that yet?
I have not. I got to do. I saw C-section and I saw a vaginal birth.
Oh, awesome. Well, that's cool. Good for you. Um, So if you ever get the chance to sit in on a version, I would encourage it, but it is kind of scary to watch. They are not the like most gentle of things, okay? And usually moms are very uncomfortable during them, okay? So if you ever get a chance to watch one, I would encourage it if it's something that you want to see, but they can be a little like not the most pleasant things. So, external cephalic version is what happens when an OBGYN attempts to rotate the fetus from a breech position to a vertex position by placing their hands on the outside of mom's abdomen and manually turning the baby. All right. So as you can imagine, it is a little bit of a uncomfortable sensation for these moms. This is something that is not able to be done whenever moms are like close to full term, right? Because there's not enough room for the baby to turn. So usually these are done like anytime after they get their GBS swab usually. So like 36, 37 weeks is when we're potentially going to attempt a version if baby hasn't turned on their own at that time. Um, so there's also internal versions where an OB will reach in and try to turn an infant that way from inside. That is extremely rare and it's only performed in emergencies. Okay. I've never seen that done before, where a provider will physically go in and try and turn a baby like internally. Like I've never seen that and I hope never to have to. But the external cephalic version is something we can do, especially for moms that are wanting a vaginal delivery, to try and turn that kid. So, what is the nurse's role in a version? Okay. We are going to put that baby on a monitor. We are always going to perform a at least 20-minute non-stress test to confirm that that baby is doing okay. If baby does not have a reassuring category 1 tracing, fetal heart rate tracing, we are not going to do a version. They are not an eligible candidate for one. We're going to have an ultrasound at the bedside so that that OBGYN can confirm fetal presentation. In fact, determine that yes, baby is still breech. So we are going to still need to do this procedure. And then we may administer a tocolytic to help relax the uterus. In some cases, if mom is not able to tolerate the positioning or the version, I've seen it before where sometimes they'll offer mom a spinal for the procedure, but that is like very rare. We would have to monitor them for a lot longer following the procedure, obviously. Um, with these patients too, obviously we are going to need to monitor them after the procedure, whether it was successful or not. Usually it's for at least 4 hours we're monitoring them because the number one risk with aversion is sending a patient into labor. All right, uterine rupture and onset of labor are the biggest risks whenever we're doing an external cephalic version. Another important thing to note, an Rh-negative patient must receive RhoGAM prophylactically prior to this procedure being done, all right? We just need to do that because delivery could be potentially imminent after aversion, so we need to be prophylactically managing this.
What's the percentage of successful aversions? Is it like half and half or more successful than unsuccessful?
So I have seen it be successful. I've also seen it be unsuccessful. But then I've also seen it where an OB will turn a baby and then the mom comes in labor like 2 weeks later and the baby had turned back. So let me look it up for you because I don't know the exact percentage. That's a great question. So it literally is about like 58% success rate. So the success rate, it says the Cleveland Clinic. This is Cleveland Clinic, so it's not just Google. Success rates are generally higher for people who have given birth before, which makes sense. Okay. Compared to the first time moms. So yeah, it's about 50-50. Personally, if my baby was breech, I don't know if I would do a version. In just my experience, what I've seen, like, I don't know. I don't know if I would do one. I would have to be convinced, I think. But to each their own, if it gives you a chance to have a vaginal delivery, have at it. Let's try it.
Yeah, just wondering if the benefits outweigh the risk.
Yeah, and that's a great question because it's like you can have a vaginal delivery, but also this version could be unsuccessful and you still might have to have a C-section right then, right there. Because I've had it before too, where we've done a C-section version, and they always are done in the OR. The surgery team is always on standby. because one time we had a patient, we were doing a version, and the baby's heart rate dropped into like the 40s, and it wouldn't come back up, and we had to do a stat C-section, like right then and there. So
Mm.
for me personally, I don't think the risk is worth it, but to others it is. So yeah, but that's a great question. All right. Another OB procedure that we see very frequently, and this is common, obviously, would be inductions of labor. So there are different kinds of inductions. There's elective, there's medically indicated um, inductions, and these can use different kind of methods. And we're going to talk about some of the methods here for induction of labor. So we use either chemical or mechanical initiation of uterine contractions before spontaneous onset. So that means we are actively giving patients contractions who have not had any at all. Elective induction requires the patient to be over 39 weeks of gestation. So my OBGYN doesn't offer elective inductions. So some OBGYNs will not. They will have you either go on your own or it'll be medically indicated or they wait until you're over 41 weeks and then they'll induce you. Okay. Which now that I'm not pregnant, I respect that and I can understand that. But when I was pregnant and I was 39 weeks, I was like, hey, how about an elective induction? And they were like, nope, sorry. So, but it's okay because it worked out. It was all fine. Um, what is the biggest indicator of a patient's for a successful induction of labor? It is our Bishop score here. So a Bishop score is a tool that a provider will use to determine if the cervix is favorable for an induction. Okay. So what it does is a provider will check a patient's cervix, and it's basically a grading scale based on how soft is the cervix anterior, is baby's head down, what is the fetal presentation, and then how high or how low is the baby in the pelvis. Okay, so it takes all of those criteria and puts it on a scale, and we get a grade. So if the patient scores an 8 or more, that is considered their cervix is favorable and um, they can get an induction. That being said, some providers will still do a Bishop score, but it's more of like okay, we'll see what your Bishop score is, but even if you have a Bishop score of 3, we'll still sign you up for an induction. Okay, so some providers will use this as an indicator, others will just kind of do one, but still offer the induction if the patient wants one. Okay. Cervical ripening methods. Okay, there's chemical, mechanical, and physical. So a chemical cervical ripening method are referring to medications, a group of medications known as prostaglandins. So the biggest ones in this group would be Cytotec, Cervidil, prostaglandin gel. Cytotec is the one that we use or that I see the most frequently. So Cytotec is a little pill that is usually placed up by the patient's cervix vaginally. And what it does is it softens the cervix, it initiates low, gentle uterine contractions, and it's basically just like a very soft induction method. Like it kind of gradually gets the patient to start having contractions. It's a bit smoother of an entry into the process rather than just starting the patient on IV Pitocin, right? So those are prostaglandins. I use Cytotec the most. That's the one that you see a lot more frequently. Mechanical induction methods would be a cervical ripening balloon or a laminaria dilator. I have never used a laminaria. I have used Foley balloons, and patients do not like them. They do not like a Foley balloon. They say they are terrible. I didn't have one personally, so I never experienced it. But what you do is you will take a Foley and not you, this is done by an OBGYN. They're going to place that Foley catheter up through the patient's cervix. They're going to inflate the balloon with some water, and then they're going to pull on it so that that balloon is sitting right on the cervix, and then it's going to cause mechanical dilation of that cervix. All right, it's about as fun for the patient as it sounds. And then it falls out whenever the patient is 4 centimeters dilated. Okay, so that is a cervical ripening balloon or a Foley balloon. This image over here, what it's showing is either Cervidil or prostaglandin gel, where you would just put that gel kind of up by the cervix too. It's the same idea as Cytotec. It's just a different medication. And then other cervical ripening methods, under this category, physical, these are the things that like you read about or that people tell you to do when you're pregnant to induce labor on your own. So having sex, nipple stimulation, curb walking, sitting on a birthing ball, position changes, all those things. Those are the things that we can educate patients on, that they can try on their own. Okay. We will do nipple stimulation in the hospital setting, but it is using breast pumps. Okay, so we would put the pumps on the patient because anytime you have milk production or pumping, that stimulates the release of oxytocin, which will cause uterine contractions. All right, so that's kind of the method behind that. To be honest, I have used pumping as a method in the hospital to try and get a patient to have contractions. And it's if they're not going to have contractions, we're probably going to need to do Pitocin or something actually. Like, but we can try the pumping first if the patient isn't ready to start Pitocin. All right. And then the last one here is an amniotomy, which is artificial rupture of membrane. So that's when a provider goes in with an amni hook and will break a patient's bag of fluid. All right. This obviously can carry its own risk, right? Risk of infection. Once that water is broke, we have an increased risk of infection if our labor runs long. And also cord prolapse, because if a provider comes in and they're like, oh, I have this primip in room 17, I want to break water. And I look in the chart and her last cervical check was she's 1 centimeter, that baby is -3 station, fetal head is volatile, so that head is not well applied to the cervix. I'm sitting there like, ooh, do we really need to do this? Because we're going to have a cord prolapse. I would really rather not. Okay. But, sometimes this is the go-to method for what providers are going to do. So you need to just have that in the back of your mind when you're at the bedside. Make sure you have the things in the room for a cord prolapse. Have another nurse in there with you if it makes you more comfortable. But this is something that a lot of providers will do right off the jump. All right. So we need to be aware of that and aware of that risk. Okay, one of our biggest induction and augmentation methods is oxytocin, which I'm sure some of you or all of you have heard of this in some capacity before. Oxytocin is an endogenous hormone that is produced from the posterior pituitary gland, and it stimulates uterine contractions and it also helps in the lactation process. So, oxytocin is released to give us uterine contractions, and it also plays a major role in lactation, which we'll talk about when we start talking about our newborn medicine. Okay. We use the synthetic form to induce or augment labor. All right. In labor, we are giving like very, 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 very small amounts of oxytocin. Oxytocin is also administered postpartum, immediately after the placenta is delivered, to help with uterine contractility and to prevent postpartum hemorrhage. However, the difference is in the postpartum period, you are giving a lot more oxytocin. It's administered like a bolus. Whereas during labor, it is a very, very slow rate that goes over an hour. Okay. Oxytocin has a very short half-life. It's 10 to 12 minutes. And it's dosed in milliunits per minute. So for an example order, your provider could call you and they'll be like, all right, your patient in room 17, I want her pit started at 2 milliunits a minute and increased by 2 every 30 minutes. That's a usual standard Pitocin order, okay? And you increase that oxytocin until you get a favorable regular contraction pattern, okay? So, we need to be very cautious when we start this medication. And we need to be cautious as we increase this medication because as you see down here, a steady state is reached after about 40 minutes. All right. So if your provider gives you orders, and I hate when they do this, all right, let's increase our Pitocin by 2 milliunits per minute every 15 minutes until we get appropriate contraction pattern. I would be hesitant to move it up that quickly because you don't even know what the full effect of the dose that you have the patient running is until it's been about 30 to 40 minutes anyway. Okay. So whenever I run Pitocin, I'm more inclined to run it slower just to give that patient's body time to adapt to the dose that you have already been giving. Okay. Um, this medication is a multiple verifier, so you need to have another nurse at the bedside with you whenever you start it. Okay, it's a high risk drug, it's a high alert med, and it's because we have some serious adverse reactions that are associated with the biggest one being uterine tachysystole, so we're giving patients too many contractions, and uterine rupture as a result. Okay. Placental abruption is another risk factor. Unnecessary cesarean section, because what happens if you're giving this patient too much Pitocin. They're having way too many uterine contractions. We're not giving baby adequate amount of time to recover in between each contraction, so they're now hypoxic, and baby starts having decelerations, and it could be simply because we introduced too much Pitocin at one time. All right. So if baby starts looking like crap on the monitor, that's going to be one of the things that is going to indicate to an OBGYN, okay, well, maybe we need to have a cesarean delivery, right? And this is avoidable, right? If we would just take our time and introduce the Pitocin at a slower rate, we may be able to save these moms from having unnecessary medical intervention, okay? Any patient that has been on long-term oxytocin use is at an increased risk for a postpartum hemorrhage because that uterus has been given medication to increase the strength and frequency of contractions. So it's going to need that Pitocin in the postpartum period to continue to increase the strength and frequency of those uterine contractions. All right. And like we said, fetal hypoxemia and late decelerations as a result for decreased oxygenation and not an adequate amount of time for baby to recover in between our contractions. All right, so we need to monitor these patients if they're on Pitocin very, very carefully and very closely. So these patients, this infant is going to be monitored continuously if they are receiving oxytocin. All right, moving on. We'll talk about augmentation of labor. So augmentation refers to the stimulation of uterine contractions that have already began spontaneously, but they're either not frequent enough, we're not having enough, they're not long enough, they're not intense enough to produce cervical dilation and fetal descent. Okay, so we're basically just adding something on top of the contractions that they're already having to strengthen the contractions that are already there. So indications for this could be hypotonic uterine dysfunction. So, like I said, their contractions aren't strong enough to produce a cervical dilation, or the contractions have completely stopped, or we're in the active phase of labor and it's stalled. The labor has stalled. The most common augmentation method is introducing oxytocin. The next most common would be the amniotomy or the rupture of membranes. And then if we want to try nipple stimulation, we can get out a breast pump and give that a go. All right. For nursing considerations, we need to monitor our patients continuously, assess for tachysystole, which is greater than 5 contractions in a 10-minute period, and then titrate our oxytocin per protocol and run that Pitocin as your order stands. All right. Okay. So a very common thing that we'll see at the bedside, that is an OB procedure, would be a vacuum assisted birth. So this is an operative vaginal delivery, I guess you could say it. So this is what happens when a provider will put a suction cup or a kiwi, it's called a kiwi, on the baby's head. And as mom is pushing, they are pulling with that suction cup and pulling the baby's head down through the vaginal canal. All right. It sounds about as great as it can sometimes be a little bit intimidating and intense to watch. So the provider, why would we do this? Let's say that mom's pushing effort is decreased because she's exhausted. She's not pushing effectively. That is a big reason why we might do a kiwi. Baby's head may be a little bit asynclitic, they may have an asynclitic presentation. So we may put that on the head to try and get baby into a better position as we're pulling them down through the vaginal canal. But we do need to have some requirements associated with this in order to have the best chance of this being successful. So mom obviously needs to be completely dilated. We cannot try and do a vacuum assisted birth on a mom who's only 8 centimeters dilated, first of all. Baby's head needs to be down. It needs to be a vertex presentation. The head needs to be very well engaged. And oftentimes, whenever I'm assisting with the Kiwi delivery, providers don't like to do them until that baby is pretty low in the pelvis, okay? They will not be putting this on a patient if the baby is in a -3 station. Like it's not successful and it's not going to produce good results, okay? Obviously, the water has to be broke so that we can actually get to the baby's head. And then no suspicion of cephalopelvic disproportion. So we need to be sure that this baby's head is actually going to fit appropriately down through the vaginal canal, okay? So here in the diagram, you can see it. That suction cup is applied. The provider will apply negative pressure, and that suction cup will be on the baby's head. In a lot of hospital settings, they're only allowed like 3 attempts with these Kiwis to get this baby to deliver before they have to call a cesarean section or do some other type of intervention to deliver this kid. So what they call it are pop-offs. And that's part of the thing that, and you guys don't need to know this, I'm just giving you extra information because it helps me remember stuff. Whenever a provider puts that suction cup on the head, if that suction cup releases spontaneously off the head as they're trying to deliver the baby, that's considered a pop-off. And they are only allowed to do 3 attempts, okay? They can only have 3 pop-offs before they have to give it up, okay? And that is because every time that suction cup pops off, it's pulling that baby's head. It is causing trauma and damage to that baby's head, and that can cause subdural hematomas, cephalahematomas, lacerations, bruising, hyperbilirubinemia, jaundice, all those things that we do not want. So that is why they're only given a certain amount of attempts before they have to do something different, okay? So our risk factors associated with this type of delivery. We're going to see perineal tears or lacerations because this is considered a traumatic birth. Mom can develop a hematoma or that buildup of fluid, blood near like the labia or near the vagina. From a neonatal standpoint, like I said, they run the risk of having and developing a cephalohematoma or a subdural hematoma, scalp lacerations. In a severe case, baby can have seizures because of enough intracranial pressure buildup and brain damage. And then hyperbilirubinemia, because anytime there's any type of injury or laceration, based on the compensatory mechanisms of the baby, they are going to have jaundice or increased bilirubin as a result of injury, okay? So this is how their body compensates for an injury. It's going to release more of this bilirubin to help try and dissipate that injury and cause them to have some jaundice, okay? This swelling that we see here, this molding of the baby in this picture, that is almost expected with a vacuum assisted delivery. We see it quite frequently and it usually goes down on its own. The big things we really want to monitor for are those cephalahematomas and the subdural hematoma because that's way more concerning. Forceps assisted birth, we're not going to talk about this as much because it's not as common. An indication for this is a prolonged second stage of labor, so mom is having difficulty pushing. Fetal indications could be if baby's heart rate is suddenly tanking and we need to get that baby delivered more abruptly. We may be employing the use of forceps. If baby has some certain malpresentations, we can use forceps to try and get baby into a different position. Delivery of the aftercoming head in a breech presentation. So if mom comes in and they're delivering breech, or if there's a provider who is licensed and practiced and is allowed to deliver breech, forceps can be used to deliver the head after the butt and the rest of the baby's body have been delivered. All right. The risks associated with this are listed here for you below. So the lacerations, urinary retention, and hematoma. For baby, it would be bruising, abrasions, facial nerve palsy, and subdural hematoma. So these forceps basically would just go around the side of baby's head, and it's the same idea as a kiwi. The providers will just use them to kind of guide the baby and pull the baby through the vaginal canal to birth them. All right, amniotomy or artificial rupture of membranes. This is when the providers go in with that amni hook and they nick the patient's bag of water, causing it to rupture. Um, it can be used for induction augmentation or to place internal fetal monitors. If we need to place a fetal scalp electrode to get a more accurate fetal heart rate tracing, they may rupture water so they can place an FSE. If we need to place oh my goodness, I just blanked out. An IUPC, an intrauterine pressure catheter, to monitor our contraction pattern and our contraction strength. This is something that we may need to perform an amniotomy for. What are our responsibilities during an amniotomy? We want to make sure that baby's head is down. So we need to make sure the provider has it either documented in a previous ultrasound, they feel the head with their fingers with a cervical exam, or they have a bedside ultrasound verifying vertex presentation. We need to assess our fetal heart rate immediately before and immediately after the bag is ruptured to detect for any signs or symptoms of a cord prolapse. So if baby has a giant prolonged deceleration where their heart rate all of a sudden drops to like 40 beats a minute and it's not recovering, it's safe to say that that patient had a cord prolapse and we need to go back for a C-section. Things that nurses document for an amniotomy would be fluid color. So is it mech stained? Is it clear? Is it blood tinged? Is there any odor to it? Is it clear? Is it purulent? And then how much is there? So if patient is polyhydramnios, they're going to have like a whole lake come out, okay? If they're oligo, we might only see a slow trickle. So these are things that we're going to want to document at the date. And then you're also going to note the time of rupture, because we want to be able to keep track of that to evaluate our infection risk. And then that little note is there telling you about cord prolapse. Okay. Any questions so far? I know this is a lot of information and we're really breezing through it. You guys are doing great. Okay. Everyone stick with me. We got like 30 minutes. So let's talk about C-sections, okay? This is a transabdominal incision of the uterus performed to preserve the well-being of the mom and the baby. These can be elective, scheduled, or unplanned, all right, depending on clinical indication. So common indication for a scheduled C-section is they've had one before. Baby is diagnosed with known Marfan syndrome. They have a placenta previa. You cannot deliver vaginally with a placenta previa. Or baby is malpresentation. So a lot of the time, if baby is breech, that's probably the most common. Breech presentation and the fact that a patient has had a C-section or prior or a repeat C-section are the two most common reasons why we have C-sections. Okay. C-sections come with their own set of risk factors. Same with vaginal deliveries, right? For maternal risks, we are worried about infection at the incision site. We're worried about injury to adjacent organs. And then we're also worried about thromboemboli, okay? Them having any blood clots, all right? For baby, we're worried about birth injuries. They can still have birth injuries with a cesarean delivery. We're worried about asphyxia and also respiratory compromise. Babies that are born via C-section have a higher instance of respiratory distress syndrome and some respiratory difficulty post-delivery simply because they are not getting that squeeze from uterine contractions. Okay, so as a baby who's being birthed vaginally comes down that vaginal canal, they are getting pressure and they are having pressure applied to their chest, which is ultimately pushing down on their lungs. It is helping evacuate fluid that they may have swallowed as they're descending through the vagina. This is obviously not taking place during a C-section. There's no squeezing, there's no pressure being applied to the infant. So if they're swallowing the fluid, a lot of the time that baby is not evacuating that fluid at all. So they're going to have a little bit of tachypnea. they're going to have a little bit more respiratory distress. They may have gurgly lungs. They may have some some more difficulty with respiration following delivery. Okay, so that's something to note. Um, Anesthesia options with a cesarean would be a spinal for any of those C-sections that are elective or scheduled. An epidural if the patient had an epidural in labor and we have to convert to a cesarean section, or a general. And if we're doing a general, it's because we are doing a stat. All right. We are not doing general anesthesia for an elective C-section. The only reason we would do a general anesthetic is if we need to get that baby out immediately and we need to just put mom under quickly. Okay. We're not
So,
doing, oh, sorry.
sorry. So I just witnessed a couple weeks ago in the clinicals. Mom went under general anesthesia, and it was a scheduled C-section because she was allergic to epidural.
Oh, well, there you have it.
Yep.
That's another reason to do one, I guess.
Mhm.
And then did they get that baby out pretty quick?
They did, and that was her fourth pregnancy, and of course a fourth C-section. So we witnessed some uterus massages outside of but it was awful. It was amazing, but also it was a little bit traumatic.
Yes, yeah, that does not sound like a fun C-section to witness. No.
Yeah.
But that is very interesting. I mean, I guess yeah, if she has an allergy
Mhm.
to the anesthesia, she's gonna have to do a different kind. So yeah, general.
Right.
But that does increase
Hmm.
like that is definitely not
That
preferred.
is definitely not preferred.
Right.
Wow, that's interesting. Um, the only times I've seen a general anesthetic be used for a C-section are when we're doing it emergent. But there was actually one time where the mom's spinal was one-sided and we had her draped and everything, and we were doing a test on her belly to see and make sure she was completely numb. And she was like, I actually can still feel it on my left side. And the anesthesia provider tried to rethread and redo the spinal, and it was still one-sided. So we just did a general because he couldn't get the anesthesia to cover the entire area that he needed. So that was one time I've seen it without it being an emergency. But they do get those babies out like right away. So
Yeah, I had a general anesthesia because I did had twins, and there was emergency C-section. So
oh
it
wow.
happens really quick.
Yes, it
Yeah.
does. That's scary. That is not
Very. Hmm.
wow. Yeah, the generals they usually do it pretty fast if they're gonna have to do it that way.
Hmm.
So whenever we talk about C-sections too, we're gonna really talk about our surgical incision techniques because this determines how a patient is going to be able to deliver in the future. Okay. Um, so if a patient gets a vertical or a classical incision, which is this one over here, that is going dissecting them down the middle from their umbilicus down to the top of their pubic bone. This is going to increase their risk of uterine rupture in future pregnancies just based on how that incision is. And then if they have an incision like this, they are not candidates for a VBAC. They cannot try and do a vaginal birth after cesarean. Okay. So you definitely will need to know that. A low transverse incision or one like this is preferred. That is what most of the time happens now because it lowers the amount of blood loss. It reduces a patient's risk for a rupture. And also, they're a little bit more discreet. Like it's not going right down the center of your belly. So patients can still like wear bathing suits and they can, it's more preferred because it's, like I said, just more discreet. All right. So our uterine incision type is going to determine our future labor eligibility. Okay. So, what is our role as the nurse in the perioperative phases? So, when mom is back during the surgery, we're going to help position the patient on the OR table. We're going to be monitoring baby. We're going to still have baby on the monitor up until they're draping and they're prepping her stomach. We're going to maintain sterile field, and we are going to be placing a Foley catheter prior to the start of the surgery. All right. Immediately post-operatively, we're going to be recovering that patient. The recovery schedule for a C-section is a little bit different than a vaginal delivery. We're usually doing way more vital signs on patients who've had C-sections. We're recovering them for a little bit longer. We're doing vitals Q 15 minutes. We're going to do fundal checks Q 15 minutes usually for the first hour. We're assessing pain. And we're staying at the bedside mostly to help with breastfeeding and help with all that stuff. Post-op and postpartum, we're going to help get mom up moving as soon as possible to decrease her risk of blood clots. We're going to do incisional care, make sure it's nice, clean, and dry. If we need to take a dressing off or change a dressing before they go home, we're ensuring how to do that and educating the patient on how to do that. We're also going to help with breastfeeding, and we're going to do discharge teaching with them as well. All right. So we mentioned VBACs briefly. What we're talking about here is a trial of labor and delivery, a trial of labor and vaginal birth after cesarean. So a TOLAC is whenever we observe mom and baby over a specified amount of time to assess the safety of vaginal birth attempt, okay? So we may start putting the mom into labor to try and see how the baby and how mom are going to handle it to determine, is this patient a candidate for a VBAC or do we need to get her in for a C-section? Okay. It requires continuous fetal monitoring in a facility capable of an emergency C-section, which should hopefully be most of them. VBAC considerations, like I said, if they have a classical incision, the one that goes straight up and down, they cannot do this. They are not a candidate for it because of that risk of uterine rupture. Primary indications, so who would be a candidate for a VBAC? If a mom had a previous delivery and her C-section from the previous delivery was a result of baby was breech or baby had some fetal distress or her labor was just a disproportionate or a dystocia, that often doesn't reoccur. Okay, so those are usually isolated events. So that seems to be safe for us to try and do a VBAC with this one. When is it contraindicated? If she had cephalopelvic disproportion, or we got all the way, she was 10 centimeters dilated, and that baby would not come down through the vaginal canal because it didn't fit, and she has an abnormally shaped pelvis, she's probably not going to be successful with the VBAC, and we might not even attempt it, okay? Obviously, it's contraindicated if they have a risk of uterine rupture in the past. Absolutely, we're not even going to try it, okay? All right, another OB emergency is meconium stained amniotic fluid. We talked about this before. Meconium in the amniotic fluid indicates that the baby passed its first stool before birth, presenting as green or brown tinged fluid. One of the causes could be physiologic maturity. So this is a normal, baby is having a normal GI function in a term or post-term fetus. The risk for meconium increases with gestational age. So the baby is just mature enough that they're going to pass their first stool in utero. Or it was hypoxia induced, so they had some type of stress event that caused them to have meconium or pass some stool in utero. Hypoxia will trigger peristalsis and anal sphincter relaxation, causing intrautero defecation. This is a sign of fetal compromise, okay, like we had talked about earlier. And then a vagal stimulation. So umbilical cord compression will induce vagal stimulation in a mature fetus, stimulating meconium passage. All right. The primary risk with this, which we'll talk about more extensively whenever we get to the newborn medicine side of stuff, is meconium aspiration syndrome, which is a severe form of aspiration pneumonia. We need to notify the neonatal team immediately at delivery. So if my patient all of a sudden starts developing meconium fluid during labor, I'm calling the pediatrician on call and having them come to the bedside for delivery. I want to make sure that there's at least 2 NRP certified professionals at the bedside who can provide care for this newborn if need be after delivery, because we're probably going to have to do some resuscitation, okay? Not always, but it can happen. So we need to be prepared. here's our shoulder dystocia that we've already been talking so much about, and we're going to see a little bit more about it. So, you guys already know what it is. It's when the baby's head is delivered, but that anterior shoulder gets lodged underneath the pubic bone. Okay. It's identified by the turtle sign, and I want you guys to star, highlight, circle. You need to know that turtle sign is associated with a shoulder dystocia. So, what that means, baby's head, you're going to see baby's head peek out with the contraction. And then as soon as the contraction's done, it goes right back in. It's going to peek out and it'll come back in. That is 100% turtle sign. That means that we have a shoulder dystocia. Okay. Risk factors, big baby, maternal pelvic abnormalities. If mom's had a shoulder dystocia before, there's an increased risk of having another one with a second or subsequent pregnancy. A prolonged second stage of labor can increase our risk. And then obviously our complications that arise from this. The biggest one is fetal asphyxia, hypoxia, clavicular humerus fracture, and a brachial plexus injury. For moms, we see hemorrhages, we see vaginal, perineal, and rectal trauma and laceration, and rectal injury with these patients with this condition. Managing shoulder dystocia. So the first thing we're going to do is McRoberts maneuver. We talked about this last week. This is what happens when we have a nurse on either side of mom, and each one of them take one of her legs, and they pull her legs out down to the edge of the bed, and then they quickly shoot them right back up towards her shoulders. This can flatten her lower back and rotate the pubic symphysis to widen her pelvic outlet, which is going to in turn release that shoulder. Okay? The other thing we're going to do is apply suprapubic pressure. So we're going to apply firm downward lateral pressure just above the pubic bone to dislodge that anterior shoulder and release that shoulder. Okay. Usually we use suprapubic pressure at the same time that we're doing McRoberts. Those are used together. If McRoberts and suprapubic pressure are unsuccessful of releasing the anterior shoulder, we're going to do Gaskin maneuver where we put the patient in hands and knees or all fours. This is kind of just trying to use gravity to assist in releasing that dystocia, right? That shoulder. If you're going and you're using Gaskin at that point, I would be preparing for operative delivery, okay? Because that is kind of our last ditch effort in releasing the shoulder. So we're going to need to prepare for operative delivery. All right, in a cord prolapse, and I can almost guarantee you guys are going to have a question about cord prolapse on your exam, so make sure you're very familiar with this, okay? This is what happens when the cord lies below the presenting part. It's most common after we rupture fluid, and signs include a variable or prolonged deceleration, so that baby's heart rate is going to drop, and it's usually going to stay down, all right? Contributing factors. If the patient has a long umbilical cord, greater than 100 centimeters, which it's almost impossible to know that before the baby is delivered because we cannot accurately measure that in utero with ultrasound, okay? If baby is in a malpresentation, so they are breech or they're on a transverse lie where they're laying horizontal compared to the mom. If baby's presenting part is unengaged, it's not well applied to the cervix, it's floating kind of above, there's a lot of fluid, anything like that, the cord can just slip right down past that presenting part and out into the vagina. Okay. What do we do? What is our immediate nursing response? We are going to call for help. Okay. You want people at the bedside. But the other thing you're going to do, one of the first things you're going to do, probably the first thing you're going to do, you're going to put on a sterile glove and you're going to insert your hands and your fingers into the vagina. You're going to find that presenting part and you're going to lift it upward to release pressure off of the umbilical cord that had slipped down into the vaginal canal. Okay? Because if we have that presenting part resting on the umbilical cord, that is cutting off oxygen to the baby, okay? So we want to release that pressure so that the oxygen can circulate and that we can get air and oxygen to the baby as we're trying to get this patient back into the C-section for delivery, okay? With your finger and your hand up in the vagina, you're going to try and help that patient reposition. Okay. We want them in a knee chest position or a extreme Trendelenburg, modified Sims, anything that's going to use gravity to get baby's head down off of the cervix and off of that umbilical cord. Right. You are probably not going to do this part, but you need to have your other nurses that are hopefully at the bedside with you do this. You want to wrap the exposed cord in warm, sterile saline towel. You're going to apply an O2 mask to mom. You're going to increase IV fluids, and you're going to monitor fetal heart rate continuously. And then we're preparing for immediate birth. Oftentimes, if there's a cord prolapse, the nurse that is in the bed with the patient providing that pressure is going to have their hand up in the patient up until they're back in the OR. That patient is draped with with that nurse still there. And then once the provider has made that incision, then that nurse can release their hand. Okay. So that patient is riding back to the OR on the bed with the patient. That is how important that is. Okay. All right. Another emergency is their uterine rupture. This is whenever that there's a disruption and separation of the uterine wall layers, including a previous scar. The most common way we would see a uterine rupture would be during a VBAC, whenever that patient's previous surgical scar starts to dehiss. Okay, that is the most common cause of a uterine rupture. So, like I said, scarred uterus is a risk factor. Multiple C-sections is a risk factor. If this patient has had multiple pregnancies, like I'm talking, this is her 8th pregnancy. Uterine overdistension, so we've got twins, we have a lot of fluid, we have big babies. Any type of trauma, so like motor vehicle accidents, injuries, anything like that. Prevention would be obviously not letting any patient who's had a classical incision attempt a VBAC. We need to monitor closely for tachysystole with oxytocin because tachysystole can also increase our uterine rupture risk. And then management depends on the severity. They may require emergency laparotomy or a hysterectomy depending on how severe the tear is, okay? So these can get pretty scary. All right. An amniotic fluid embolism, also known as an anaphylactoid syndrome of pregnancy, is rare but catastrophic. So this can happen during labor, at birth, or within 30 minutes after delivery. So how is our patient going to present if they've had an AFE? They're going to have sudden respiratory and cardiovascular collapse. They'll have acute hypotension, their blood pressure is going to tank, and they're going to become hypoxic. All right. They're also going to enter into a state of DIC. They're going to go into DIC too. All right. Predisposing factors, if they've had a rapid labor, that can cause an amniotic fluid embolism. Like we talked about earlier, precipitous delivery can cause one of these. Meconium stained fluid can cause a bolus. Labor induction and augmentation can increase the risk for these, a placental abruption or previa, a large amount of fluid, eclampsia, or post-term pregnancy. Okay. These patients are going to code, okay? They're going to rapidly decline, and we are going to need to resuscitate them. So what are we going to do for them? We are going to initiate CPR immediately, all right? If this patient is still pregnant and they throw an embolism, we are going to have to do a perimortem cesarean if mom does not recover within 4 minutes. Okay, so this can become pretty serious, and we need to deliver the baby. And sometimes that means we're delivering the baby and doing a cesarean in the room, in the ER. This is like worst case scenario, guys. I've never, fortunately, knock on wood, seen this before, but it can happen. Okay. With delivery of the infant, this optimizes fetal survival, obviously, and it can also help facilitate maternal resuscitation if we just deliver the baby and deliver the placenta. All right, we're going to do a couple practice problems here because we still have about like 14-ish minutes. We'll do these practice problems, and then if we have a little bit of time and anybody who wants to, we can do some of the review from that PowerPoint that I went over in my review until we're done for the week, okay? So let's start here. The The nurse is monitoring a client who is in the active stage of labor. The nurse documents that the client is experiencing labor dystocia. The nurse determines which risk factors in the client's history place her at risk for this complication.
So 3.
Previous difficulty with infertility.
I would go with one.
A 54-year-old that's pregnant, yes. Advanced maternal age, definitely.
Oh, select all and apply.
Yeah.
I was like, there's a couple maybe.
Yeah, you're good.
1 through 4.
1 through 4.
So the correct answers are 1, 2, and 3. So an age of 54, a BMI of 28, and prior infertility. Okay. So 54, that is advanced maternal age. Okay. Anything over 35 would be considered an advanced maternal age. A BMI of 28 would be classified as overweight. So that can increase labor dystocia, right? Because we talked about overweight pregnancy, obese pregnancy can increase our labor dystocia risk. Prior infertility is listed as dystocia risk factor because that also could be like reproductive technology if they have to utilize anything like that, right? So those are things that we're going to be seeing. Oxytocin alone is not a risk factor, only uterine hyperstimulation would be, and then that potassium level is normal, okay? Over here, we have them listed again for us, the risk factors for labor dystocia. So our advanced maternal age, overweight, or somebody who's of short stature sometimes can have, show signs and symptoms of labor dystocia. Electrolyte imbalances, previous infertility, uterine overstimulation, malpresentation or cephalopelvic disproportion, epidurals, an early analgesic use, and then maternal fatigue or dehydration. All right. So a nurse is in the labor room preparing to care for a client with a hypertonic uterine contractions, they're uncoordinated, erratic in frequency, duration, and intensity. What is her priority action?
Three.
3.
Number 1. Okay, so let's talk about this here. So hypertonic contractions are painful, frequent, and uncoordinated. The primary intervention for these is pain relief because we want to try and promote a normal labor pattern and allow that uterus to rest. So we're trying to slow these down. All right. Why would we not want to do an amniotic? Let's go back. Hold on. All right. So an amniotomy and oxytocin would be used for hypotonic dysfunction because we would want to try and get more uterine contractions. In a hypertonic contraction pattern, if we're trying to decrease the amount of contractions, we're not going to want to do anything that could cause us to have more. So an amniotomy and oxytocin are both things that can cause more contractions. Ambulation also, that's contraindicated. For a patient who's having too many contractions, we need them to rest. We're probably going to give them fluid. We're going to give them fluid. We're going to give them pain management. I know a lot of the time in this instance, they may give a patient Vistral. That is a medication that can be used to kind of relax them and decrease uterine contraction. Okay, so that's why we would provide pain relief in this situation here. All right, the nurse is performing an assessment on a client who has just been told that a pregnancy test is positive. Which assessment finding indicates that the client is at risk for preterm labor?
Two.
Correct. The patient has an underlying history of cardiac disease. So preterm labor occurs after the 20th, but before the 37th week. A history of medical conditions like cardiac disease is definitely a risk factor. Medical conditions can compromise uterine perfusion, and that will trigger early labor. Okay. Age 35, why that doesn't matter. Elevated risk begins at greater than 40 for a first pregnancy. A hemoglobin of 13.5 is normal. Anemia would increase our risk. But since that's normal, we're not worried about it. If a patient's 20 years old and they're of average weight, that's normal. So we're not really going to care. And that's not a risk factor. Key preterm labor risk factors are listed there for you. They have pre-existing medical conditions. They have multifetal pregnancy or a uterine overdistension, anemia, so they're having decreased oxygen to the uterus, or they're younger than 18 or older than 40. They've had prior OB complications, or they have used substance abuse, or they have social risk factors that can contribute to preterm labor. All right. Another one here for you. The nurse has created a plan of care for a client experiencing dystocia. What is the priority nursing action?
2.
2.
Yeah, we want to monitor our fetal heart rate. So dystocia is prolonged or abnormally painful labor, places our baby at risk for hypoxia, right? So our fetal status is always the priority. So we need to continuously monitor the fetal heart rate to show any signs or early detection of non-reassuring patterns. Everything else is really just like not the priority in this standpoint. We always want to consider fetal well-being, oxygenation of our baby, anything like that takes precedence over family communication or position changes or comfort measures, okay? Um, so there it's kind of broken down for you as to like where our priorities would be in this question. All right. So then I have listed here the things that we have due this week. So let me stop my screen here, stop my share. So it looks like we have a couple minutes. Do you guys want me to pull up some practice problems just to do for the last couple minutes of class? I can pull up that PowerPoint from the exam review and we can at least get like maybe 2 or 3 in.
Yes.
Yeah, why not?
All right, let's do it. Let me pull that up for us.
Will you what chapters again are they for this exam?
Let me pull up the syllabus because I never remember. All right. They are going to be over the content that we covered from week 4 on. So it's going to be 18, 19, 20, 21, 11, and 12, and then chapter 17.
Thank you.
You're welcome. Let's get this PowerPoint pulled up. We'll try and get a couple questions through here. Maybe if it loads.
Both are young.
Can you hear me?
I can hear you.
Okay. Um, I'm not sure if you got my emails in the beginning. I know this is totally off topic, but I'm trying to make sure I counted. Um, in regards to my week 3, or I emailed you, so I'm not sure if you responded back yet, but
Okay.
emails are good.
Yeah, I
Yeah,
will take a
I'll try to
peek.
class.
Yeah, I can take a peek after class and see. I'll find your email for sure.
Okay.
I
Yeah,
have
because
a quick
for whatever
question.
reason,
Sorry,
I have
what?
a quick question.
Yep.
Hey, is anybody having issues logging in to Zoom through her shared links? Because I can never get through the link she shares.
Yeah, the
Is
link
it
didn't work today. I had
huh?
problems too.
The link that I sent.
Yeah, it doesn't work.
It
Oh,
doesn't work.
okay.
So that is her ID in the announcements under her email. But it's going to be the same ID. Doesn't matter about the link. Just that what helps me. I don't look for the link because the link didn't work
Can
last
I?
week or it didn't work this week. But if you type it in her ID and then your Zoom window will remember that ID. So you just go to the ID for the next week.
Oh, and it looks
That's
like
my
she just sent it. So thank you so much for sending that in. So that is my Zoom ID. So you just go to the Zoom website and you just put that in and it'll take you right here. It might honestly be easier than the link because I copied the link from Zoom. So yeah, I can try and send you another one, but honestly using my Zoom ID might be better. And guys, my PowerPoint's not loading, so I'm so sorry. I did post it on the exam to review in Canvas. Okay, so you guys should be able to download that and use that as extra practice. But I can't get it to pull up right now, and we're also a minute away from being done with class. So if anybody wants to schedule extra time to study or review with me, I'm going to end our recording now.